I want to thank everybody for joining. Sorry for we had some technical difficulties starting today. But my name is Kimberly. I'm the Managing Director for the Chronic Pain Network, and I want to welcome you today to, which I believe is our 4th Patient Engagement and Research Rounds webinar. A few housekeeping items. We're recording the webinar today for those who can't join at this time. We'll post it online on our YouTube channel for viewing at a later time. So we ask that you mute yourself and remain on mute through the presentation to reduce the background noise. Throughout the meeting, if you'd like to type any questions into the chat box, send them either to the coordinating center or myself or to everyone. And at the end of the presentation, we'll read out the questions in order to minimize background noise again. The idea behind the Chronic Pain Network Patient Engagement and Research Rounds is to share and harness the network's collective experience in patient engagement and research. And as we grow our experiences, we want to grow in our knowledge in patient engagement and add it to our collective knowledge we have in the network through these rounds. Today's webinar is titled Using Two-Eyed Seeing Approaching Indigenous Health Research, Making Time for Tea, with John Syllaboy and Margot Latimer, who are the chairs of our Indigenous Health Research Advisory Committee. So I'll introduce John. John is Mi'kmaq from Eskasoni and Millbrook First Nations in Nova Scotia. He works in social and cultural development, health and education policy, as well as research and community development for Atlantic First Nations communities. His projects include the IWK Health Center for Aboriginal Children's Pain Research, National Community and Stakeholder Engagement for Research, and he serves as a consultant for a number of First Nations issues. Joining John today is Margot. Margot is a professor in the School of Nursing and is cross-appointed in the Department of Medicine at Dalhousie University. She holds a scientific appointment at the IWK Health Center and is faculty in the IWK Center for Pediatric Pain Research. She works closely with the community to mobilize Indigenous knowledge and co-leads the CIHR-funded research Aboriginal Children's Hurt and Healing Initiative with the Eskasoni Health Director, Sharon Rudderman. So over to you, John and Margot.
Thanks, everyone.
Wonderful. Thank you so much for your patience while we got things organized today. Just a little slice of reality for John and I in our travels. We're actually in Winnipeg today, meeting with the Mont Carmel Clinic, which there's a large Indigenous population here in downtown Winnipeg, and they're going to be working with us as we expand our research across Canada. So while we thought we had everything organized, we had some technical difficulties getting online here because we needed to use one of the computers. So bear with us as we move forward with this, but this is just sort of the reality of what it is to do the work that we're doing. So hopefully you'll appreciate it as we move forward. So I'm going to let John start off for us.
Hello, everyone. My name is John R. And my process and my involvement with the research started about 4 years ago. And really, it is bringing to the table community voice and experience and community engagement when it comes to doing this type of project. It also, the responsibility is making sure that the protocol, the cultural perspectives, the Indigenous knowledge, and honoring our way of doing things is respected throughout the research project. It's more than a research project, in my opinion. It's always been a process of relationship building and building onto that relationship building to make sure that we do this process correct as best as possible. So the ownership and control of the data, for example, is community owned and community driven. And we honor that. We have to make sure that we move that way and we move forward so that we always keep that in mind. We always start off with our presentations to share a little bit about the about who we are. A lot of people in Canada, believe it or not, may have or may have not experienced working with Indigenous populations. And in fact, a lot of people in clinical care say that, you know what, I've not had a chance to attend to Indigenous patients, for example, and a lot of people don't really know that they are attending to Indigenous patients in their clinical situation. So we share this data that's here. We are the fastest growing population in Canada, and we continue to be so. The the Aboriginal children population under 25 is the fastest growing cohort still. And we, in our community, meaning the Indigenous voice of the equation, always say that we have an opportunity here to make sure that we get the process right, so that we make sure that we put people into the future workforce, education, and into healthcare at a more positive light than historically has been this reality. The next slide basically is to show people again what we've, all the purple dots are the Indigenous populations in their areas, and we're everywhere. We're in every single city or close by to urban areas, and we're not in the forefront to a lot of people, but the question always is in the back of our minds is that sometimes people don't feel safe to self-identify when they go to health clinical situations, and we often have to, look at that and say, why is that? So the Indigenous population across Canada, we share this data as well, saying that Canada, being the wealthiest and part of the top 10 countries in the world, with a Human Development Index at a high third, for example, when it comes to Indigenous people, especially children, we drop down to a 67th at that level when it comes to comparison, let's say, with all other areas. There are communities in Canada that don't have safe drinking water. We don't have adequate health care. There are crowded homes, and it's unsafe for some people. So when we compare that to other developing nations, we're in critical situation when it comes to that part. So we also share information about the Indian residential school. We always introduce the topic. You wouldn't believe how many people still do not know about the Indian residential schools. And in our presentations, we're often surprised that there are blank stares in the audience when we share information about the Indian residential school. 150,000 children had attended the schools in Canada, and the last one closed in 1996, which is current. There are current generations that know about, that are aligned with that experience. And there are still people living with, survivors living today in Canada that have gone to Indian residential schools. But we also shared the fact that intergenerational trauma from the Indian residential schools has major effects on our well-being in our communities. And we have kids in care, for example, that equal to about the same amount of kids that had gone through the Indian residential school. And in connection with that idea is that we had, Dr. Amy Bombay, who's a colleague of ours, had shared this data that you're looking at on the slide here that says that people that had gone to Indian residential school, that intergenerational effect goes down in families from one generation to the next. This is what shows that. A parent or grandparent that went to school and the following parent that went to school, and then how that affects their children as well. So of course, when we look at the Indigenous populations across Canada and we look at current reality about Aboriginal households, like what I had alluded to in the low education attainment, we talk about the inequities in health and access to health. And most populations, the most vulnerable populations, of course, are children and anybody who is affected by all these circumstances. So we started, of course, looking at what it is to understand pain is. So some of the highest rates and conditions across Canada with pain-related conditions are these ones that you see here: the musculoskeletal, dental, chest, headache, and ear, and some of those areas are concentration. Okay, How are we doing? Oops, what happened here? There we go. So untreated pain, of course, we've seen firsthand through this study and previous studies as well that untreated pain affects many different areas. You can see here. One of the big areas that I always get scared about is about the language development part and how pain may affect the learning capacity for a child and the overall development of a child as well. But the existence of our cultures may be at risk here when we don't address children's health properly, and that's very significant to our communities as well. It's a high priority area. So I'm going to hand it over to Margot, and I'm just going to talk about a little bit about the experience that she knows as well.
Great. So in 2012, the Health Council of Canada went across the country to determine Indigenous people's experiences with the healthcare system. And so John's just sort of painted a picture of history, geography, and health conditions. But in terms of this survey that was done with Indigenous people, they learned that people were not feeling welcome in our healthcare systems. They're feeling fearful, powerless, discriminated against, they've been denied painkillers, and so it sets up a really, I guess, unacceptable circumstance that we have a population with high health needs, but they're not feeling welcome or cared for in our healthcare system. To further sort of make this point, people have said, oh, that's in the past. But this is something that was posted on a clinic's door just last June. And so, attention Native patients, please don't ask for tranquilizers or pain medication. So this sort of circumstance is alive and well, and health professionals are frustrated by this as well. They don't have the capacity or the ability or maybe the knowledge to know how to cope as well. So we're just trying to gather up community knowledge to help us understand what is the best way forward for all this, and our research is a vehicle for that. So we're integrating knowledge from community. We use what we call a two-eyed seeing perspective, which takes together Indigenous knowledge and Western perspectives, because that's the interface in which healthcare is meant to be happening. And so we're gathering up both of those perspectives and using the information that we're gathering to improve practice, policy, to further research and education as well. So as I had said, we are using what we call a two-eyed seeing perspective. We have a small clip from one of the communities that we work in. Elder Albert and Merdina Marshall are a husband and wife couple, and they coined the term two-eyed seeing, which I said is meant to take the best of both those perspectives. And so we have a clip of Elder talking about what that is. I'm just going to see if it'll play here. Can I just confirm you can see that?
Yeah, we can see it, Margot.
Okay, great. Maybe it's just loading. Yeah, it's just loading.
2IC is very much, in my humble opinion, inherent in my way of thinking. I think it's imperative that we apply those lessons learned from our forefathers as to how do we weave back and forth in these two worlds in which we have to coexist without compromising the essence of who we were as a people.
The sort of Western lens tends to be tactical and data-driven, but we know that people are a whole package of heart and soul, spirituality and beliefs, and so 2IC combines that in a much more holistic way.
When we look at knowledge around how we understand pain and hurt, for example, we also want to address how we want to learn about healing, what it is about pain management that we know in our own traditions that manage our own well-being.
We need to educate healthcare providers to have a better understanding of the differences in the needs of services and supports that First Nations populations need.
We have to be really focused on what are the needs, the values, the desires and goals of the individual, and that's primary. And secondary is all the things we can do. So I think, the 2IC model is really about the whole human.
We're trying to bring those two perspectives together, and we've done that through different methods. So, for example, we use healthcare utilization data to look at what First Nation community members seek healthcare for, and do they seek care for the same types of issues, and do they get care for the same types of issues?
And the community was taking part in that process. We're taking part in the training of clinicians, building curriculum, developing health context for understanding what it is that Aboriginal people go through when it comes to health and well-being, understanding the history behind some of the things that would have happened that help us understand who we are today even when it comes to our well-being.
That co-learning will create transformative change. And that's exactly what we need to move forward with our healthcare system and to support these children and communities to be healthy for the future.
When you invoke your 2IC for a non-native person, I think it would be very, very helpful if they can just momentarily put on another lens so that as this exchange is ongoing, you will be able to then begin to train yourself as to how can I weave back and forth between these two ways of knowing.
Okay, now the tricky part.
Okay, so close up here.
So that's what we've been doing. We've been weaving back and forth between these two ways of knowing. And the way we've been doing that is we've been working with communities to mobilize their knowledge to be able to share with health professionals. And we use this through our research methods. So the importance of placing this, though, in context of the Canadian Institute of Health Research, for example, sort of reflecting how the wording is, or the philosophy of the SPORE network, for example. Patient is considered from a very broad perspective and inclusive of family or community voice. And so that community voice piece is what's so important with Indigenous health research, because that's exactly how we see the work that we do as active partners in this research process. But we have to look back again. Every time we try and go forward, we also have to look back. So we look back at the Royal Commission on Aboriginal Peoples, and as part of that RCAP process, the OCAP principles, ownership, control, accessibility, and possession, are the principles that guide our work with Indigenous communities. And so those principles are meant to protect Indigenous communities in terms of their research that's done within the communities, the knowledge that is not meant to be taken from communities, but it's meant to benefit the communities in terms of their wellness in every sense of the word. And so I just want to play another quick video here. It's from the First Nations Indigenous Governance Center, and it's around data protection, just to give you an idea of the way Indigenous, or from the Indigenous perspective, knowledge is considered and how it's meant to be protected. Let's see if this will.
People have always understood the value of community, the importance of respect, and the need to protect our resources for future generations. And today, one of our most important resources is information. First Nations people have always been information gatherers. When we track and hunt or gather food from the land, we're engaging in information gathering that has a direct and important impact on our lives. First Nations people understand that information isn't just about numbers and surveys. It's about culture, identity, traditions, and self-determination. That's why the First Nation Information Governance Center was created. Since 1996, its mission has been to uphold the values of OCAP, a set of principles designed to protect First Nations ownership and jurisdiction over their information, and ensure that First Nations people are the stewards of their own information. OCAP ensures that First Nations people have ownership both individually and collectively as a community. It puts them in control so that they can decide how it is used, by whom, and under what conditions. It ensures that they have the right to determine and define access regardless of where it is held. And it defines possession, ensuring that they have the power to use their information for the benefit of their own communities. Possession is key to making ownership, access, and control possible. Taken together, the First Nations principles of OCAP embody one important idea, that First Nations people understand their own needs and are in the best position to govern their own information. The right of First Nations communities to own, control, access, and possess information about their people is fundamentally tied to self-determination and to the preservation and development of their culture.
Sorry. How do we do that? There we go. You can start.
So,
First Nations people have always understood the value of community, the importance of...
all right, and back to the screen.
Just that side of there.
So I just want to explain one little aspect of this part. So the OCAP principles are bound to all of the communities and researchers across Canada, but when it comes to the application of that, that may differ from one area to another, from one community to another, even from one, let's say, nation to nation with another. And not that we have the recipe for doing research, but when it comes to Indigenous, using Indigenous knowledge into research, for example, we in Mi'kma'ki and the Mi'kmaq, for example, are bound to ancient confederacies or treaties that determine how we work with other nations. And that's embedded in our culture, it's embedded in our language, and it's embedded in how we establish relationships with other people. So a lot of people don't get that when they're working with First Nations or Indigenous people. We do get it. I know how to work with Maliseet. I would know how to work with, let's say, another culture. Maybe not follow the same exact principles, but we know what it is important when it comes to relationship building. So that's why we said making time for tea type of thing. It's important that the relationship building process is on a continuum. It's a non-linear approach to doing research. We can't just dictate time concepts, for example. We can't dictate resources that are from the top down type of thing. We have to make sure that we work in coordination with the ground crew, the community. That's where the knowledge is at. That's where massaging that knowledge, handling that knowledge, and keeping that knowledge there for use for the community is very important. And decisions and knowledge sharing even to that point is very, very important. So sometimes when, for example, researchers have deadlines for manuscripts and deadlines for meeting funding deadlines, and that whole, we all know about the funding deadlines, for example, each year when it comes to quarterly needs. We can't operate in the same linear fashion when it comes to doing research in our communities. We have to really work in partnership with the community that is showing us how that process needs to be, and that nothing about us without us is true to the 2IT approach when it comes to doing research, and that's very important. That's how we've had success in the Atlantic in making sure that we do that. An example is that Margot and I have been working on manuscripts, and our group has been working on manuscripts, and then it's been written, but then we have to go back to the community and make sure that we have the knowledge right. We have to make sure that the data we're sharing is permitted to be shared. We need to make sure that everything is in line so that when we do share it, community knows first what we're sharing, and then it goes out. And it's a slower process, but it's truer to what community research is from our perspective.
So just to give you a little bit about our own work, the aim of our Aboriginal Children's Hurt and Healing Initiative is to use this 2IT approach to understand how Indigenous children express their pain so we can work together with community to reduce it. So just to give you a little flavor of how we've applied this 2IT approach and community-engaged approach and the outcomes that we've had. So we use different types of information from community. We've accessed a unique data set that's called the Unamagi Client Registry, where the health director that we work with and her colleagues have created this unique linking system between community members and the provincial healthcare system. We also worked with artist Alan Syliboy. He's a Mi'kmaq artist who worked with 4 communities and their youth, and we had circles or conversation sessions with elders, teachers, parents, and children and youth. And in terms of the healthcare utilization data, from a pain perspective, we learned that the children from a 0 to 17, it was a retrospective 17-year data set, that the First Nations children had significantly higher rates of every single physical pain-related diagnosis. These are physician diagnoses. Yet they were significantly less likely to have a mental health diagnosis, which was surprising when we shared that with communities, because that's not their, from the mental health perspective, not their day-to-day experience. They weren't surprised by the physical pain diagnosis. However, when we look to the art-based data, the youth that participated in those art sessions, almost 40 youth from 3 provinces, painted emotional pain. So even though they talked about physical pain, when they were provided the opportunity in a culturally safe space, they painted emotional pain. So it just speaks to the importance of engaging the community in a meaningful way, finding a space and a culturally safe space that the youth felt that they were able to share their perspectives. And then from the conversation sessions from all groups in the community, we learned that children are quiet about their pain. They try and be brave, but then when they try and get help for themselves, there's a lot of frustration in terms of the communication or the miscommunication, which results in a lot of frustration, chronic pain, on-release pain, and repeat visits for the same conditions. When we asked community members what is it that you want your health professional to know? And if there was a new health professional coming to your community, what would you want them to know? And when we looked at these results, we thought, gee, you know, that these resonate for researchers as well. This is what we share with people who ask us, you know, what should we know before working with community? And community members say they want clinicians to know their history. They need to know where we've come from to know where we're going, is what we're told. They want humility in healthcare. They don't want to be judged based on where they've come from, the clothes they're wearing, etc. They want health professionals to know the dimensions of health. So for Indigenous people, health is more than just physical. It's emotional, spiritual, mental. And the sense of tribal consciousness around communities when they're seeking care and who's important to them when they're discussing their care decisions in terms of their family and extended family and others. And also, of course, the crucial part of the importance of communication. And all of these are critical, not only just to healthcare, but also to the research process and engaging community. So they know that we understand the context in which we're working. We have just another short documentary that we want to share with you around the outcomes. Just kind of a snapshot of some of the things that we've done in our work.
My name is John R. Siliboy. I'm from Eskazoni Mi'kmaq Nation, or First Nation. This is where I grew up. This is where I learned my language. And this is where the Aboriginal Children's Hurt and Healing Initiative story began with the IWK Health Center and with Dalhousie University as well.
About 10 years ago, I was working with the complex pain team here at the IWK Hospital. And so we noticed that we weren't seeing many First Nations children and youth referred to our clinic. Estimated maybe 2 out of 800 referrals were First Nations kids, and wondered why.
They wanted to understand from a cultural perspective and from a Mi'kmaq perspective how it is that we can understand what pain and hurt means. Also to understand how it's expressed by our children.
Within the Mi'kmaq language, there's certain words that exist, but there's certain words that don't exist. For example, using the word pain doesn't exist in the Mi'kmaq language. They refer to where they hurt and where the pain is within their body. You can understand why there would be a disconnect in the communication that exists between healthcare providers and our Indigenous or Mi'kmaq people.
We know that health is not just that physical cut that you have, but that whole context of mind, body, spirit, or mental, spiritual, physical, and emotional. They're all interconnected. You can't separate one without the other. We know that from our cultural perspective. We know that those are children that express that way.
Jerry, call pharmacy, please. Andrea, Jerry, call pharmacy.
When we decided to use the artwork as a possible venue, a circle conversation with each of the groups with Alan Siliboy, and interestingly enough, in the conversation sessions, they only talked about physical pain.
I had dental pain, or I had stomach ache, and then Alan had told them or asked them, could you go and sit down and start drawing what this pain looks like to you? And their narrative, along with their art pieces, told a dramatic story about the emotional aspects of pain and hurt. So after we just had a conversation with the kids that talked about physical pain, there was an overabundance of expressions of emotional pain and mental pain. To them, pain is pain.
My father was a residential school survivor, and so I'm a descendant as well of residential schools. All of that trauma and hurt and pain really has done significant harm to our communities.
They have been socialized to kind of mute their pain or or suppress their pain as a way of coping with it. The art revealed that these youth are feeling a lot of emotional pain as represented in their artwork, which was in direct contrast to the healthcare utilization data, which showed they were significantly less likely to receive a mental health diagnosis when we compared them to a non-Aboriginal group. So I think it was a validation for us on many levels that art is an excellent medium to help youth sort of express themselves, but also as a research method to help us collect that information.
It was right there. It was right in front of us. The research showed us with those kids that it's not just physical pain, and we can't look at it just from a physical perspective. It's emotional, mental, and spiritual as well.
What we'd like to do is help health professionals understand that this is the way that they may be when they present in an emergency department or a physician's or a nurse practitioner's office.
That understanding is very important, because then we had to switch gears a little bit and not just ask about physical pain. We had to understand what their emotional pain is as well.
I think it really taught us how important that cultural safety is, to create that safe space for youth to be able to share their perspectives in a way that is meaningful and reflects a community-centered approach.
And we have to make sure that those objectives that we have of children right now that are being born have better outcomes than the children that were coming out 10 years ago, 15 years ago, 20 years ago. I guess it's on it. Let's get. Jolanda, I guess it's on it. My name is John R. Did you get the point? So back to our slides.
Yeah. So you can see there are a lot of dimensions to the work that we've been doing. Having the trust of the community, creating meaningful engagement that allows the knowledge to come out in a way that is authentic, that is respected, and that is shared in a respectful way that's helpful both to the community members but also to those we're trying to reach in terms of health professionals and learners. The overall our work is built on the community engagement approach, which we recognize is essential at every step. We are working on addressing the Truth and Reconciliation Commission's calls to action. We're creating university and clinician curriculum with the work that we've been able to do. We're creating training and mentorship opportunities for both Indigenous and non-Indigenous students, and also communication mechanisms, such as we've created an app for youth to share their perspective in a story-based manner. And we also have, as part of the Chronic Pain Network 4, established an Indigenous Health Research Advisory Committee that has that we're working towards mobilizing some knowledge around process of conducting research with community.
The Indigenous Health Research Advisory Committee basically, as a researcher or community person on this research process, we try to look at how we do research in a community community way or community protocol, and there's nothing really written out there in stone or written out there that's been shared, and that's part of the charm working with our communities, is because it's always moving, it's always something that's evolving, and part of that is what we're trying to do, is capture that sense of spirit in research when we work with our communities. And it's something that's that needs to be validated, but it's validated within each territory. It's validated within each cultural dimension and language. So as we're moving forward, we're going to have to rely on those community knowledges and those Indigenous knowledges of other territories to make sure we get it right. We have a sense of direction from how our experience is, but we rely on building that relationship through our advisory committee of elders and Indigenous guides to make sure that we get it right when we approach other areas.
And I mean, interestingly enough, it's such an iterative process. This is Elder Jane that you see in the picture, and we were actually at her house for tea when that picture was taken. But one of the challenges that we've experienced during this process of the Indigenous Health Research Advisory Committee is engaging elders and community members meaningfully, but our methods of using teleconferences or video conferences don't necessarily work for the way they want to share their information. So, you know, we're constantly learning too how to make this process work and how we can meaningfully engage community people to have a voice in all of this. So we'd just like to say thank you for your attention and your patience with some of the technical issues. We look forward to some of your questions.
Great, thank you, Margot and John. That was fantastic. I really enjoyed that. I think we've got a fair group here that we could actually open the questions to, if you want to unmute yourself to ask the question. I think that will work with this group. So I'll give it a couple of minutes. Mary, I see you've unmuted yourself.
Hi, thank you so much. I learned a lot. My parents hail from Cape Breton, so I love the picture in particular. But I guess my question is relating to knowledge translation, and so in terms, how would two-eyed seeing or the unique approach that you need to take with research change perhaps the way that you would share evidence? I assume you would want to share it first with the community and have them as a first filter. But anyway, I just wondered if I could put that question out there to you.
Yeah, I can answer that. Mary, thank you for the question. Two-eyed seeing is, the metaphor is like the wampum belts that we have from the old alliances between the Wabanaki Confederacy, where we had the Mi'kmaq and the Maliseet and the Penobscot and the Passamaquoddy nations of the main area, where it was understood that we had a relationship with people outside of our culture and within each other as well. So knowledge sharing is the same way. Doing research is the same way, but it has to come from the community first. The first part of the process is to understand that the priorities are identified from the community, the needs are identified in the community, how that process to gather knowledge and data is also from the community. It's stored in the community. So everything that we try to do is in line with that, and also build capacity when there is something that it may be missing. For example, one of the big things is about Indigenous researchers, health researchers especially. We don't have many students in that area, so part of our capacity building is to make sure that our students are involved in that process. And an example of knowledge translation would be when we were working with Eskasoni First Nation and interviewing elders, we had a student who is a pre-med Indigenous student who's on her way to becoming a doctor one day. And when we were doing the interviews, the knowledge translation was already taking place right there. The elder was talking to us in Mi'kmaq and sharing her knowledge, and that first source of knowledge went to us, being the Mi'kmaq-speaking persons in health research. So the translation of knowledge was taking place right there. This is even before it was brought back to IWK or brought back to transcripts or brought back. You know, we looked at it as a priority that we make sure that the knowledge that we're sharing stays within the community. Then we try to share it outwards afterwards. And in doing so, we have to go through protocol. We have to even go through ceremony if need be. We have to acknowledge that the data that we're sharing is also embedded with spirit of knowledge. So the clinical world doesn't look at it that way, but we certainly do.
Thanks so much. It is a shift in thinking and something that I know it's very new to me, but I really appreciate this opportunity to hear from you. Thank you.
Thanks.
Thank you, Mary. I guess one of the things that sorry, it's Kimberly here, that I wondered about in coming from the CIHR and the reporting and this that type of angle is the challenges like when you spoke of the timelines and differences to be considered there. I just wondered, is there any particular, what's been the biggest challenge in terms of funders and some of those reporting things that we're used to that might be amended slightly?
That's a good point. So, well, I think that because we have been working with communities now for more than 10 years, we anticipate those sort of deadlines, and CIHR, for example, gives you lots of warning, like several months when things are due. And so it's a negotiation, and I think that because we have such strong relationships with communities, when I first started, there needed to be a lot of time spent building a trusting relationship. Communities, the first question they will ask, and even as John and I go across the country engaging more communities, the first question we're asked is, how will this benefit our community? And so you can tell people how it will, we think it'll benefit, but we show them those videos where we bring community along with us, and it's the community that sort of maybe builds the relationship with other communities. We're connecting communities across the country. So I know it doesn't directly answer your question, but I think because we've built these trusting relationships, we now have some autonomy within our team that the health directors and chiefs trust us in terms of our decision making and what it is that we feel comfortable in engaging, and then going back to community and saying, how do you feel about this? Or, we create the reports and share it with the community and say, is this okay for us to share? So everything goes back to the relationship. And so I guess because we've been able to do that, we've had good success with those kinds of deadlines, etc.
I think the other part is that at IWK Research Services, for example, have been very accommodating in our process as well. They had to adopt a two-eyed approach as well when it came to doing funding, for example, and hiring, for example, students. Instead of hiring them through our IWK Research Services, we had negotiated in doing it through the health centers or through the community. Then funding would flow through that area. Capacity development is always in process. So we have to follow community protocol, but then the IWK would understand that, but we needed to massage that into it as well. We had to go back and forth and be the messengers in that process, and we certainly are big messengers in that whole process. And Mary, back to the question about the change in sharing. The sharing, a lot of researchers have a I approach, meaning I'm the lead research. I'm the one that's leading the writing. I'm the one that owns this knowledge. It's not so. It is not so in our way of doing the research. And doing community research with any of the Indigenous communities across Canada, one has to understand that level of collective consciousness and approach to doing research will have to change from the I to the our. And that's very important in relationship building, because that sense of transparency about doing research is part of the relationship building process and building trust. And if we erode that, then we'll lose that sense of trust. And it's a continuum. It's got to be ongoing. And we learned that. That changes, that shifts the way the sharing process as well. So I think that's important, and it's an important piece to make sure that you keep in mind when you're going to be working with our communities. And those timelines will shift. We don't look at it in a linear fashion, we look at it in a circular fashion when it comes to doing relationship building. You got to go back and forth.
Yeah, thanks again.
Okay, thank you. This is last call for questions, and if there's not any more, I'm going to thank you so much for such an informative webinar. Really enjoyed it.
Hi, Rebecca Lee here from the Patient Engagement Committee. John and Margot, you both spoke to the importance of starting your research very much grounded within your specific community. And I guess my question is, given that there is very much this lack of a word for pain as we know it, and perhaps even the stoicism that you spoke to in terms of not necessarily communicating when a child, for example, is feeling pain, how do you necessarily know which community members are living with pain, and how do you engage those members to feel comfortable enough to work with you?
That's a great question. And I think, you know, the process that we talked about, we couldn't share all of the information that we've gathered from community, but we have, community has told us what's important to them, what's meaningful in terms of that process when they seek care in the healthcare system. What's important to them is that they feel safe when they come to the healthcare setting, that they're greeted in a way that means they're respected as people, that they feel that their needs and their culture and beliefs are respected, and that we take time to develop that relationship with them, just like we described in the research, that the health professional takes that time to listen to their stories. That's one of the pieces that we're teaching health professionals, is that story-based piece of information sharing, and that the way we teach health professionals to assess pain based on overt signs may not work with Indigenous people. And so it's just a completely different way of thinking about how to develop that relationship and what needs to happen before you're going to get to the piece where they're going to share their information with you.
I'll just add, it's not like we would call out in the community and say, who's feeling pain? Recruitment for, let's say, patient-oriented research wouldn't be quite the same way, let's say, just make an announcement in a clinical situation. We have champions in the community that would know different health determinants that people feel in the community or who are dealing with it. We work with the health directors, for example, that lead us to people that have different pain experiences or different pain situations. They would be our first point of contact. That community would be, the champion in the community would be our resource person. And then we would start working with that building of the relationship. And then eventually, for example, with the children, what we had done is go through the school, and again, we just talked about the project. We had people come up and express interest, but that's one way of doing it, was working with a lot of ground supports. We wouldn't go into community setting and just say, can we do research on pain? That simply. We have to have a lot of buffers in between before we can even get to that point, if that helps.
Last call. We're at 3:01, so I don't want to go too much over this time, so maybe we'll go in a webinar. And thanks, John and Margot, that was fantastic.